We come to session 31, glycometabolic changes during the woman's life. And let me start with Professor Djuro Macut from Serbia, and he's going to talk about polycystic ovary syndrome as a pre-diabetes condition. Thank you very much, Professor Macut.
Dear chairpersons, dear Inas, first I would like to thank you for the kind invitation to come here and to represent, I can say, European Society of Endocrinology. So I send you all best regards from the President of the European Society, Professor Jérôme Bertherat from France. Should I take this one or? Okay, maybe this one, it's easier. So today I would like to inform you about the possibilities how to assess on the best way the glucometabolic changes within the life of the young person that is continuous disease as the polycystic ovary syndrome is. So this is the most common endocrine disorder during especially the woman's reproductive period, and affects about 10% of the whole population according to the older, I can say, diagnostic criteria from the NIH from 1990s, but up to 25% according to the newer one from Rotterdam from 2003. So if we are talking about the definitions, you can see on this table here on this slide, the three criteria that were evolving during the 20 years of period. So the first ones were from 1990 with the necessity of have both of those conditions, so the hyperandrogenism as the clinical or biochemical, plus the chronic anovulation with the irregularity presented by the irregularity of menstrual cycles. Later on in the Rotterdam in 2003, the ultrasound examination was assumed to be very important. So 2 out of 3 of those are related to the definition of the PCOS, while in 2009, the Androgen Excess and PCO Society said that the obligatory one is the hyperandrogenism, which is defining the disease as the hyperandrogenic state with women with the completely specific consequences, and today I will talk about the metabolic ones. So if we are looking on this really relatively complex slide, you will see that there are some inputs and outputs. So from one side we have the effects of genetics and the obesity, which is the core, on the top of everything. And then we have the insulin resistance that is developing during the life, also the hyperandrogenism. On the other side, we have neuroendocrine dysfunction, etc. And then we have the metabolic more and reproductive more phenotypes. So within the metabolic ones, we have glucose intolerance and diabetes with lipid abnormalities and increased cardiovascular risk. But there is also the non-alcoholic fatty liver disease that is something very characteristic and now recognized as one of the steps toward the definition of type 2 diabetes. So during the life, we have different stages of the development of PCOS. So from the in utero period to the peri-puberty to the adolescent and adult period until the aging. So in these different parts, and we are the adult diabetologists and endocrinologists here, so you can see that with PCOS we have anovulation, hyperandrogenism and obesity, but later on during the life we can see that the majority of the outcomes are related to the metabolic issues. So cardiometabolic consequences are the major things in the adult life of the woman with the PCOS. But what is the very, very important consequence of the long-term risk is type 2 diabetes. And you can see on this slide that among the cancers or the left ventricular dysfunctions, the type 2 diabetes is the only one which is nicely spreading the lines. So the expectancy of life is much more diminished or decreased with them. So what are the key metabolic derangements with them? So in this very complex slide, I don't want to take you time on the analysis of all the molecular and biochemical pathways, but you can see that it's rather complex from the insulin receptor, which is on the surface, and through the different cascading mechanisms, we can lead toward the change in the glucose metabolism, but also the growth and development leading to the cell proliferation. And you can recognize that we are very close to the different proliferations. So the diabetes later on, or the insulin resistance from the beginning, is just showing us the possibility that this could lead to something which is not expected to be even after the metabolic changes, which is, for instance, the endometrial cancer, not very well diagnosed or not very much focused on today. So we have different also targets, and we are using different drugs. One of those are the PPR gamma agonists. So glitazones are something that is a little bit more forgotten, but very useful drug in combination with the other insulin sensitizers or new biological therapies that came also in the field of diabetes are very useful drugs for the future, I believe. So I will come back just 2 steps before, which is the old the seminal work by Andrea Dinev that shows us that we have the really higher response of the insulin with the obese, but also the lean women with PCOS, showing that they have their own type of specific insulin resistance related to hyperandrogenism. This is clearly showed in comparison to the hyperandrogenism isolated with the ladies with the hyperandrogenic anovulatory cycles, but those with the polycystic ovaries that are combining all those that I showed on before are really much more prone to develop insulin resistance. This is the confirmation. So with the clamps that we are not unfortunately using so much in our research, we can say that those ladies are spending less glucose, and this is the outcome of the increased amount of insulin, which is not functional. So we have much more pronounced insulin resistance, which is monitored through the clamping outcomes measured by the utilization of glucose. If we are looking into the obesity as the cause of the PCOS, we can see that dyslipidemia is among the main causes, and in different stages of obesity, so different grading of obesity, you can see that dyslipidemia presented in the black bars is predominating. So lipids are the second target in the ladies that we have to follow during the life. And this is one of our very first papers that we published many years ago, showing that we have 3 elements that are the most important that we have to follow, monitor within those patients. So the first one is the dyslipidemia mentioned with the HDL decrease and triglycerides. So we have the situation with lower levels of HDL. On the other side, we have oxidation of LDL, which is more pronounced with them. So the conclusion is that we have subjects that are prone to develop atherosclerosis later in life, and we have those indices that are also very useful to measure if we are looking at the longitudinal cohort studies with the populations. And the third element is the insulin and HOMA, presented by this surrogate marker that is not the best way how to assess the insulin resistance, but we can see that with those women we have elevated both insulin and consequently also the HOMA index. And this is something that we try to analyze in the cohort population between Greece and Serbia. We showed that the prevalence of metabolic syndrome is much higher in the women with polycystic ovaries in comparison to controls if we use the National Cholesterol Education Panel Adult Treatment 3. So this is the specific and the most severe, I can say, diagnostic tool for the measurement of the metabolic syndrome. So we can see that in our region, it's more pronounced. You can see that in the United States, in the selected populations, which are the studies of John Essler, show that even 43, such high number can be seen in some of those. And in the fastly growing communities like the Sri Lankans, because they are really changing the way of living, can we also notice very frequent and very exposed population to the metabolic syndrome. So what are the risks associated with type 2 diabetes? The obesity is among the key ones, and this is one study that is the analysis of the data of the previous studies, and we can see that in the huge number of analyzed patients, over 60,000 PCOs, about 8,000 were those with the type 2 diabetes, and you can see that the relative risk is 3 times higher with them to develop the type 2 diabetes. If we are looking into the analysis of the data, we can see, if we are looking on the obesity, we can see that the obese PCOs in the comparison to the non-obese PCOs are also much more present, so 3 times higher. But if we go to the non-obese PCOs in comparison to obese, again, we have even higher ratio of almost 4 times. So polycystic ovaries plus obesity are the crucial element to develop everything related to metabolic outcomes. Now we are coming to the diagnostic tools. What can we use to diagnose the irregularity in glucose metabolism in those specific group of women? And this is one of the recent studies given by the Spanish authors that showed that if we are looking on the fasting glucose, if we are comparing the fasting glucose and oral glucose tolerance test, you can see in the lower part of the slide that those with the OGTT assessed and then differentiated between the weight categories, between lean, non-obese and obese, and also with the hyperandrogenic state, you can see that the hyperandrogenism is obviously affecting some of those, and we have increased number of diabetics here, but also that the OGTT is maybe better discriminating those with diabetes than those without. So OGTT should be used according to the Spanish authors. And here with the ROC curves, you can see that both of those, basal glucose, but also the OGTT, could be used for the definition of the these disorders of the glucose tolerance. We wanted also to give some contribution to this. So this is the study that was conducted in the 4 countries, Greece, Serbia, Poland, and Bulgaria. So we pooled all the data, and then we analyzed the frequency of glucose dysregulation. So you can see that even by using the basal values and the values from the OGTT, you can see that in each category we have actually the definition of some irregularities, but even with the basal glucose, but we must say and notice in this study that about 30% of all the ladies with the OGTT had normal glucose levels, concluding that we have to perform the OGTT in all the population. And this is something that was used in all the guidelines that are taken from the clinical setting, that we have to introduce the OGTT to all of them, and everything is perfectly fitting to the study of the group from Renato Pasquali from Bologna, recently, published about 10 years ago, but perfectly showing that the increase of basal fasting glucose of about 10 milligrams per deciliter is increasing about 50% the possibility to develop type 2 diabetes. So even with the very simple following of the glucose level, you can conclude the outcome in future. And what are the therapeutic options? So we have different of those, and they are varying according to the phenotypes. So in the previous period, the special interest group that is dedicated toward the polycystic ovary syndrome from the European Society of Endocrinology proposed specific treatments related to the phenotypes. So we have 3 major phenotypes. We have metabolic, hyperandrogenic, and reproductive phenotype. But today I will talk more about the metabolic phenotype, that is including everything that I mentioned before. So insulin resistance together with hyperinsulinemia and increased ovarian mainly production is leading toward the increase of the lipid deposits and of course leading finally to the type 2 diabetes. So we have different treatment strategies that are given on the lower left part of the slide. So we have to introduce the physical activity with dietary intervention, smoking, cessation, and then insulin sensitizers as the first line therapies. So what about the combination of the physical activity plus diet? And again, I'm going to Italy to one of the seminal studies that is given in 2011. So this is a group of women that were followed for many years. This is one of the longest longitudinal studies. So they followed in this special paper, they presented the relatively shorter follow-up of about 1 year. So in the first 6 months, they were on dietary regimen with the 1,200 to 1,400 calories per day, together with some physical activity. And then in the remaining period, they continued with the increased physical activity and some dietary follow-up. So after the period of follow-up, you can see that in about 37% of all the ladies, it was complete disappearance of all the clinical characteristics of the polycystic ovarian syndrome. So we have to go, the conclusion is that we have to go back to the dietary intervention and the lifestyle change as the first line approach to the patients and possibly risk patients under the risk for the development of type 2 diabetes. The next stage is metformin, of course, and metformin is now established as the really cornerstone for the therapies of insulin resistance. So this is the most widely used insulin sensitizers that improve especially the central insulin resistance, but also the peripheral on the lower degree. So we have the effect on reducing the androgen levels, but also the ovulation frequency. So it's a well-used tool for the induction of ovulation, so to improve fertility with them and to improve menstrual regularity. We could not affect the hyperandrogenic problems like the hirsutism, of course. It's quite a weak drug, and it's not targeting the receptors in the production of androgens. The other level of interest that we were talking yesterday on the session of gestational diabetes are inositols that are weak compounds. They are not the drugs, they are actually the supplement level of drugs, but they could be used when the patient is not tolerating metformin, and it didn't show any specific superiority toward the metformin. And it seems that could be safe in the pregnancies, but we do not have really randomized trials that are really set as the in the real clinical setting. So we want also to make some contribution in this field, and this is a study that was that we recently published on 2 groups of patients that were given the metformin and myoinositol related to the body mass index. So what we noticed during the 6 months follow-up, we can see that in both groups we achieved a nice reduction in the body weight and the body composition with the waist circumference reduced. But if we are looking on the side of glucose, really unexpectedly, we got the nice effect on the levels of basal glucose mainly. But if we are looking on the hormonal level, superiority was on the side of metformin. So you can see that we got a nice, a nice response to the level of testosterone, and even the improvement of the anti-Müllerian hormone, which is the marker of the ovulation capacity with those ladies. We are coming now to the GLP-1s, and this is the very interesting and promising area. It is licensed for the treatment of type 2 diabetes and obesity at this moment, but the polycystic ovary syndrome is considered to be the prediabetes condition. So we have to think about using in the specific cases. So this is a very attractive option for the obese PCOs, and not to be sent for the bariatric surgery. Of course, with grading system on the therapies and the introduction of therapies, we have to think carefully about whom to send to bariatrics at all. So this drug is stimulating, of course, weight loss, improve ovulatory rates and hormonal and metabolic parameters. And this is one of the recent studies that is giving us a clue toward the combined therapy. So we have exenatide here, which showed a nice response, but in combination, it showed with metformin, of course, it showed nice superiority that is here in this study confirmed by the clamp. Again, I'm stressing to the clamp, we have to investigate more and not to follow just the simple analysis of the data of the previous time. So we have to take a look in our populations, and I'm sure that the Egyptian population or the population of this part of the Mediterranean is really maybe different than our part of the same region. So we have to develop more, I think, interventional clinical studies to see how all things are going on. So in this study, it was shown a nicely recovery of beta cell function with increase of insulin secretion in them. The promising tool is probably the SGLT2 inhibitor. So this is one of the very studies of the use of the SGLT2. So empagliflozin in comparison to metformin during this relatively short study showed nice outcomes in improvement of only anthropometric data. So in the first part of the slide, in the upper part, you can see nice change in weight, BMI, and waist circumference, but not on the metabolic side. So it was not shown an improvement in all these issues related to the levels of testosterone or even insulins, whatever. So this is a good clue toward the patients with type 2 diabetes, what they are actually doing, I mean the SGLT2 inhibitors. And this is something which is, step forward. How can we assess the metabolic profilings, the profiles with the different drugs? So here we have different drugs like the exenatide, so GLP-1s on the first two blue and red columns, then the second pair is related to dapagliflozin, the third pair is related to DAPA only, and then we have combination with metformin and the central regulators of appetite. The conclusion is that if we are looking on the metabolic outcomes, the best ones are related to GLP-1s alone or in combination with the SGLT2 inhibitors. So the increase in red bars are only in the combination of with those drugs only. And this is the last slide, which is relatively old slide. It was published some 5 years ago with the perspectives in female reproduction. But what is important for you is to see that we did not move much more. So the last part of this slide, which is on the bottom, you see that we have to investigate more in the metabolic therapies, including insulin sensitizers, anti-obesity drugs, and anti-diabetic drugs. So the time actually came. We have lots of anti-obesity and anti-diabetic drugs, so we have to use them also with female population. Thank you very much.